So we are planning for replacing both side premolars and molars. You will see the intraocclusal space. So the patient is having only anterior swing pattern. You can see the intercuspation, locked intercuspation. The prosthetic space is quite decent, not a problem. But on left side it looks it reduced, right? But the photo is not taken in the correct angulation. So tomorrow take a correct angulation. Okay. So two things we have to do. What are those two things? An anemoplasty. So we have to do alveoplasty also after extraction, a mild alveoplasty. Of course, the amount of bone remaining will limit the alveoplasty. We have to see the X-ray, and we have to do a good anemoplasty also. So how much anemoplasty we have to do? We need to take a photo at proper angulation. So this kind of cases are always challenging, where we are replacing both side premolars and molars. So all the forces will go towards the premolar molar, our implant teeth. High risk cases there, especially when there is a lateral interference, they will fail easily. And since the crown edge space is very less, we will have a less abutment height also. So delay loading will be safer in this kind of situation. If the canine to canine teeth are weak or they are in the treating phase, no, then the VD will collapse after 1 year, 2 year. Then all the forces will come to the implant processes. But for this patient, the bone is quite good, right? It's almost zero bone loss in upper anteriors. So hopefully they will hold the vertical dimension effectively. So we have to plan for implants. So each side we have told 4 implants. The left side we may need to do a good alveoplasty. So behind the canine, first premolar, we are planning tilt palatally. We will engage the nasal floor. Okay, a compressive implant will do. A small labile defect is there, but that is not a problem. Anyhow, we will do a 1 or 2 mm alveoplasty. So if you see the 360 view, the main thing we have to check is how much it is close with the adjacent canine. It should not go and touch the canine. It will damage canine and the implant also will fail. The trick is slightly tilting mesially and also palatally. If you tilt palatally, because the canine apex is buccally, so the implant should go palatally. The nasomaxillary buttress implant, we come closer to the buccal aspect, but here we have to go for the palatal angulation, palatal inclination. Okay, so the second implant we will plan for the pterygoid. Okay, so whenever you are planning for pterygoid, we have to look the lower 8. So better to remove the lower 8. If not, we have to do a lot of anemoplasty for 8, even on the day of surgery itself. In this X-ray, the pterygoid is not covered, right? But if you see, the 8 is grossly decayed, and it is in communication with the sinus also. Okay, even beyond the 8 root stem, the sinus is going. That means the pneumatization is a problem here. So what we'll do is tomorrow we will take a IUP there, or we will take another CBCT in a better angulation, so that we will cover the pterygoid. See here, notch. This is the posterior wall of sinus, so we have a less space here for our drill, the implant to go. Okay, so we'll do a small pilot drill, then we will take IOPA, then we will decide. Okay, we'll see the palatal socket of 7. This is the mesibuccal root. I feel like someone else is controlling my mouse. The mouse is going automatically. Okay, we can place a wide body wide diameter 5.5 BCS here, right? We'll get engagement from the palatal socket. 10 mm implant or even 12 mm implant we can place it here. Okay, and we need to place one more implant in the second premolar. Almost this is in the first molar area. The bone is very less. Okay, so we are coming closer to the almost in the second premolar. Also the bone is very poor, right? Only 8 mm or 10 mm. Maybe if we go closer to the buccal plate, we can place a 10 mm. That's it. So very challenging. See here, we cannot do alveoloplasty here. See here, right? The bone is already 8 mm, 10 mm. If you remove 2 mm for alveoloplasty, then so left side alveoloplasty we cannot do very much. After extraction of 2-4 root stem, we can do some shaping, but not in the 2-4-2-6 area. Okay, so this is the tentative plan. We will see the right side. The right side we are going to remove the 1-5, 1-7, 1-8. So we are going to place implant in the 1-4. There is a good bone here. Palatally you have to tilt, not buccally. If it is a full mouth, you can tilt buccally, right? You can observe the relation between the canine and the implant here. If we go buccally, then it will touch the root apex. So that is why always tilt palatally. A good amount of 18 mm, 19-20 mm implant we can place. It's a very key implant. The next implant you cannot place in the premolar socket. It will be very close. Okay. So what we will do is we will place an implant close to the premolar palatally. See, even then it is showing close to the adjacent. See here, this palatal island now we can utilize. It's a very tricky situation. Otherwise you can place a short implant engaging the sinus floor. See, the sinus has come down very low. Look, in the first molar. This first molar, no? This is first molar, right? Yes, first molar mesial root. So this is the mesiobuccal root area of healed. So we can place a short diameter implant. If we are trickily drilling, then we can catch this bone. So definitely we need this bone tomorrow, right? Otherwise we have to place a wide body short implant. So the other option is in the 7. This is 7, right? 7 palatal socket. 7 palatal socket. We can the thing is the 7 roots are closed. Whenever the roots are closed, it is not ideal. The fused, right? So after extraction, there will be a big defect, a big empty socket. So we will run away from this here. Just mesial of 8 and just distal of the 7. We have a good bone. About 10 to 12 mm bone height is there. We will check the. This is 8. 8 is completely unfavorable. It's conical root as usual. So the pterygoid is also quite little. It may be challenging. The pterygoid is not covered, but it looks as though the sinus has expanded. The tuberosity area. Okay. So comparatively, this is a tough situation to manage. It is challenging in how many aspects? One is prosthetically, it is challenging. Prosthetic space is less. Okay. Second thing is occlusion wise, it is challenging. It is risky. Bilateral Bilateral posterior is always risky. Even if it is one side, that is okay. Patient can eat for 2 months, 3 months on the other side till osseointegration happens. But here, okay. So prosthetic space is one challenge. Next is occlusion is one challenge, and the third is the bone is also not very much favorable. Only the mesial implant is good. The distal support pterygoid is pneumatized. Okay, we can place a good pterygoid, but the middle segment, no, in the molars and in the second premolar, the sinus pneumatization is affected in a downward direction. So we can place only a short implant. So what the other alternative option is, we have tried, yeah, we can go for bar. See, for 2 patients in C. Lizzie, we gave bar. Delay loading 2 months, but it worked fine. Place very short implants. So we can, anyhow, we have told us the delay loading for this patient, right? 2 months. 2 months is enough. So unless the bone is very much osteoporotic, no need for even 3 months. 2 months is more than enough.
But the CH is already very less, no, sir.
Yes, that is another thing. Since the CH is very less, we cannot delay 3 months, 4 months, 6 months and all. Superadaptation will happen.
And bark space. Bark space, sir.
Yes, we need to create a very thinnest height, very much, less height bar we can. So if you are going for bar, 3 implant is enough.
Yes.
Okay, there is no need to complicate, 4 bars, 4 implants.
Single piece implant.
Multi-unit. Multi-unit implant. So I'm not talking about single piece and cemented titanium bar. There is no big advantage in using a cemented titanium bar for such short segment. For that, you can do a double welding. A thick wire double welding will act as a bar. That also we can do. But if you use screw retained titanium bar, you will get the advantage of 360-degree coverage, which is not present in welding. And the multi-unit abutment will distribute the forces. It has got a good platform, which is not present in single piece. And of course, the titanium bar advantage is always there. So we can go for a single piece multi-unit and titanium bar. The only challenge will be the prosthetic space.
Is implant screw and violin screw the same height, sir? Screw. Simpler at the
Both same. Huh?
I'm asking it.
A little bit simpler end will be less.
Lengthwise, sir. If the screw length is shorter,
the bar height will be shorter. See, the multi-unit head, the implant head, that height, that is the key. So if it is very much smaller, then the entire bar. And of course, as he told, the screw head height, head thickness, that also matters. So comparatively, both Simpladent and Bioline single piece multi-unit, they have got a bigger screw to prevent a screw fracture. They have designed, comparatively it is bigger than conventional implant, which is good actually. Never we had a breakage in screws, whereas conventional implant, the risk of screw fracture is there.